Good morning.
Good morning, honorable members of the committee. My name is Simrun Bal. I live in Hanover, New Hampshire. I am a physician and a member of the American College of Physicians, New Hampshire Governor's Council, and the New Hampshire Medical Society. And today I'm here to testify in strong opposition to HB619. My testimony also represents that of the two organizations that I have mentioned, which also oppose this bill. Today I'm testifying that as a doctor, I'm highly concerned about the repercussions of this bill in terms of the effect that it may have on New Hampshire's youth. As a physician, one of the best parts of my job has been caring for people of all walks of life. And I wanted to just share one small anecdote from my time in medical training. When I was early in residency, I was working in the emergency room and took care of a young adult transgender patient who was coming in with blood kind of seeping through the long sleeves of their shirt and from their jeans. And after examining and talking to this patient, we learned that this patient had had severe suicidal ideation from shame and bullying that they had experienced in not having supportive social environments and supportive family structures. To me, that was just incredibly unfathomable and heartbreaking. And it represents to me what happens too often, which is that transgender youth are not able to access supportive social environments and have difficulties accessing gender-affirming care. And this results in anxiety, depression, higher rates of homelessness, and higher rates of self-harm. Rates of suicide are as high as 40% in transgender youth, which means that if there are 100 people in this room, imagine that 40 of us would have attempted suicide. To me, that is, again, heartbreaking. This bill proposes to ban gender-affirming care. It would ban those supportive social structures in school, and it would legalize conversion therapy, and thus it would exacerbate the healthcare disparities that I've already pointed out. I want you to imagine for a moment putting yourself in my shoes as a physician or as a parent, a teacher, and remembering kind of that pain that you may experience if some child's life ends too early because of suicide due to the harms that this bill propagates. I do want to point out it doesn't need to be this way at all. In medicine, we follow very careful evidence-based protocols that show us the importance of accepting transgender identities that also involve the use of medications, which are carefully used to put a temporary pause on puberty. These physical changes that happen to youth can be distressing, and it allows us to temporarily halt those changes. We've also notably used these medications for the past 30 years to help children who are diagnosed with the early onset of puberty or central precocious puberty. I also want to point out that there are studies by the
15 seconds left.
Recognized American American Academy of Pediatrics that point out in large cohorts that accessing these medications is really crucial and is associated with lower odds of suicide. I think with that, I want to go ahead and close, but just recognize that this bill would put medical decisions into the hands of government rather than between the patient, family, and physician.
Thank you. Are you taking questions? Any questions from committee members? Yes, Representative Leon.
Thank you very much for being here, and thank you, Mr. Chairman. Could you submit those evidence-based guidelines for this care to the committee?
Thank you. I will do so. Thank you.
Other questions from committee members? I'm seeing none. Thank you. Representative Weber.
Thank you, Mr. Chair. We're all getting used to the space, which is not our normal home. Would you please, could I ask you a bit about what kind of parental involvement there is when you see a minor who wants this kind of treatment?
Yeah, thank you so much. So I think when I see patients in clinic, there are two sides of the spectrum. I think one side is that we really carefully want the child to have all of the supports in their life that help them make this decision, and that can be parental role models who often accompany them to appointments and help them step by step think through this decision. On the other hand, we often encounter patients who may not be supportive, and in that case, the child turns to other trusted role models in their life, like teachers, peers, and others in the community who are leaders. So I worry that not accessing those supportive social supports will mean difficulties in accessing care and going through a potential transition. Thank you.
Other questions from committee members? Yes, Representative Murphy, I believe it is.
Thank you, Mr. Chairman. Thank you for taking my question. You mentioned the medications are reversible. Is there a time beyond which they are not reversible once they are started?
That's a good question. I don't believe so, but I can look into that more definitively and get back to you. We use them often for children who have had early onset of puberty, and so we wait, a number of years until that time of puberty, is to catch up. Like if they went through puberty at age 6, for example, waiting until age 12. But I can get more definitive information to you too.
Representative McLean.
Thank you, Mr. Chair, and thank you for taking my question. So obviously, a person who's going through this, there's going to be a lot of confusion, and you talk about the bullying as well. So could you maybe describe for the committee the process that you take to go through to decide this is going to be the decision? Because for some, it may be seen as an easy way out. So what's the process that you go through to kind of get, this is the road we have to take?
Yeah, thank you so much for the question. I think when we think about transition, we recognize that it is not an easy decision to make, and we look for sustained kind of evidence where a child really feels that they were not born into the right body that fits their gender identity going back years. Often patients that I've seen in clinic will report that this began in childhood and that the people around them felt like they could not listen to them, for example, or that they felt unsafe in bringing these concerns out. So we listen to that narrative and we help patients sort of understand the journey of where it began. And I think the other parts too is that we typically have a number of different office visits where we talk through this and we think about other comorbidities, for example, anxiety, depression, things like that may make it harder to transition as well.
Follow-up?
Thank you, Mr. Chair. So, so part of your testimony, you said we really don't want to have the legislature involved in this, but from medical rules and I'm not a doctor, so but medical rules and practice, are these is this process defined, or is this pretty much different, doctor to doctor, or is it a defined protocol?
Thank you so much for the question again. And I think that this is why it's so helpful that we are having this discussion, because it really is an evidence-based process. We utilize guidance from the American Academy of Pediatrics, which is well recognized, and the Endocrine Society itself, which also publishes protocols that help us think through the transition that may be medical, involving hormone-based medications, and the psychological transition, but we use well-recognized evidence to make the decision and to go through the process. It's not like an individual making these decisions, it's really a body of evidence in the medical literature and well-recognized societies.
Other questions? Any other questions for committee members? Okay, thank you very much.
Thank you.